And good afternoon, all. Thank you for joining today's Tuesday topics, ICP for you and me. This will be a short form evaluation of increased intracranial pressure, what it really means to us, how we monitor it, and some basic strategies on how we're going to take care of patients who have increased intracranial pressure. So first of all, we always have to think about the pathophysiology and the physiology of what is actually happening inside that big old bony box called the skull. So within that bony box called the skull, there is a non-elastic sac that's known as the dura. And inside that sac, which is non-elastic, which is inside a rigid bony box, the skull, there are three major occupants. The brain tissue, that involves both gray matter and white matter, as well, my friends, as anything that is uncontrolled, like edematous fluids in the interstitium, or like free blood from a ruptured aneurysm or traumatic brain injury with bleeding inside the brain. So brain tissue is comprised of the things we normally think of with brain tissue, and that would be white matter and gray matter, but it also combines in there free water and free blood. 80% occupation by that brain tissue and everything that's incorporated there. 10% occupation by blood, and that is the blood inside of vessels. So both arterial and venous blood. And then 10% occupation by cerebral spinal fluid. Now, just reminding ourselves that cerebral spinal fluid is manufactured in the lateral ventricles, and it is circulated through a small connector on one and the other side, the lateral ventricles, to the third ventricle, a small connector to the fourth ventricle that then connects into the subarachnoid space. And in the subarachnoid space is where cerebral spinal fluid will always circulate. It provides particularly a nice cushion and some nutrients for the brain tissue. So again, we look at brain tissue, 80% occupation, blood controlled in the artery and the vein, not free blood, that's part of brain tissue. Blood controlled in the artery and the vein, 10%, and cerebral spinal fluid, lateral ventricles, connectors to the third, to the fourth, and in the subarachnoid space, 10%. Now, what's so incredibly important about this is that these are all flexible components of that incredibly stiff compartment, the dural sac and the cranium. So these are going to be flexible components. And the other thing to always remember, I like to remind you, is that your brain is actually divided into three basic parts. I'm not here to do brain physiology and brain anatomy, but the three basic parts: the right hemisphere, the left hemisphere, and the cerebellum. So the cerebellum is below, and the right and left hemispheres sit on top of the cerebellum. And separating the right and left cerebral hemisphere and both of those from the cerebellum will be dural folds. Now that's important because when we're talking about intracranial pressure, we also talk about the placement of the dural folds and whether those folds have shifted because one area of the brain has gotten bigger and it takes occupancy. I always talk about this, like separation of right and left, separation from cerebral hemispheres and cerebellum. So again, these folds, right, they're like a little tent that separate us. That must have made you nauseous, all those hand movements, sorry. But I always talk about this like something that's really old-fashioned. There used to be a very well-known film star who had very buxom breasts. They were buxom. And she became the spokesperson for then, you know, at that time, there weren't many bras to choose from. And she became the spokesperson for the Playtex bra. And she'd get on the television, kind of lifting up her buxom breasts, and she'd say, the Playtex bra, it lifts and separates. And that's exactly how I think of the dural folds. The dural folds lift the cerebral hemispheres off the cerebellum and separate the right and left cerebral hemisphere. So again, there's some flexibility here. The dura will shift to one direction or another, and the brain can actually herniate through that connection of the right and left separator and the right and left separation from the cerebellum. So really important for us to appreciate that, because a lot of what we talk about when the brain is swollen, when we look at an MRI or we look at the CT, we talk a lot about the placement of the dura, and if the dura is shifting. And when the dura is shifting, of course, that indicates that an area of the brain has gotten too big for its compartment and it's pushing over into another compartment. So you can push from right to left, from left to right, or from up to down. And of course, that's always called herniation when the brain is shifting. So really important for us to appreciate this relationship of the three components that are encased inside your bony skull and inside your relatively inelastic dura. And the reason that's so important for us to appreciate when we're talking about intracranial pressure is that our normal occupation, when everything is right with the world, the brain is a normal size, we have a normal amount of blood volume and a normal amount of cerebral spinal fluid. This is all very dynamic. It's not static. But this understanding, the Monroe-Kelly doctrine, the Monroe-Kelly hypothesis, is that when one item increases, the others must decrease. Now, that is the Monroe-Kelly doctrine. The Monroe-Kelly doctrine says that you will always, up to your capability, you will always make room for the brain. So here my brain is 80%, and now I have a brain bleed. And now I have a brain bleed, so now I have a lot more occupation inside that brain compartment. Remember, brain is white matter, gray matter, free blood, free edema. And here what you're seeing is edema and blood that's now creating increased brain occupation. Hey, my friends, don't forget, please, that when you come on board, you need to, I see who it is, you always need to mute yourself because Zoom doesn't automatically mute you. So that's okay. I fixed the mute. I didn't think I'd be able to see who it was, but I did. So very good. Just remember to keep yourself muted just because we get a lot of feedback, if not. Okay, so now you take a look at this edema and this blood. And what's happened is that the brain volume, remember, gray matter, white matter, free water, free blood, brain volume is increased. Now you're inside that stiff dura, inside that hard skull. So as that brain matter decreases, it naturally means that the other occupants, there's three, brain, blood, and CSF, those other occupants must decrease in order to make room for that swollen brain. So what happens is your blood flow, both arterial and venous, go down, and you'll reduce the blood occupation of the brain to make room for the swollen brain. And you will also shift your cerebral spinal fluid into basically into the spinal canal, shifting it away from the brain, which means you're losing some of that cushioning. And you're going to be able to do that for a period of time, and then you're going to decompensate. So this hypothesis, the Monroe-Kelly hypothesis, really simple. There is only so much space inside the dura and the cranial vault. There's only so much space without some kind of interruption. And when the brain is swollen, that means edema. It might mean that you have a tumor or that you have a free bleed. That when the brain is swollen, you will reduce your cerebral blood volume and your cerebral spinal fluid. Now, the problem with that, of course, is that as you reduce the blood flow and the blood volume in the brain, the controlled blood flow, which is in the artery and the vein, as you reduce the blood volume and the blood flow, you actually now have the potential to have cerebral ischemia. So even though there might not be a clot, you actually will have a type of a stroke because you've reduced the blood flow to the brain tissue. So that's really important when we think about that Monroe-Kelly doctrine. I'm just going to state it in another way. Brain tissue, blood volume, and cerebral spinal fluid are volumes inside the dura and the cranium that are always in a state of dynamic equilibrium. In general, you don't increase your brain tissue, but you will increase blood flow or cerebral spinal fluid as necessary. If you have edema in the brain, if you have free blood in the brain, if you have a tumor in the brain, you're going to occupy more space with your brain tissue. That means you must reduce cerebral blood flow and you must reduce cerebral spinal fluid to make room for that brain. So we just want to remind ourselves, Monroe Kelly is just all about equanimity. If you have an increase in any one, brain tissue, blood volume, or cerebral spinal fluid, then you must decrease something else to make room for it. There's only a certain amount of space here. 100% of that space is already occupied. So when one increases, the other must decrease in order to make room. Now, that's what we call compensation. But you reach the limit of compensation. And when you reach the limit of compensation, your brain will shift. It will shift from side to side or from up to down through those dural folds that are meant to lift and separate, lift and separate. So our purpose is we want to identify you when we're seeing that you're increasingly occupying your space. And one of the very first things that we're going to do is we're going to consider that we're going to remove cerebral spinal fluid to help make room for your swollen brain. Okay, so again, I can't say it enough. I just think it's so incredibly important. Cranial vault and dura, rigid and flexible. The flexible units inside, right? Cerebral spinal fluid, 10%, blood flow, and that's both venous, that's why it's blue, and arterial, that's why it's red. And your brain volume, which includes gray matter, white matter, edema, mass, and free blood. So always really important to remember that. So this is just the same. I think what's so incredibly wonderful, and not all of you are with me all the time, but especially for those of you who are with me all the time, I repeat this over and over and over and over again. Pressure, no matter what kind of pressure you're talking about, pressure is always about volume and compliance. But here we talk about a chamber that is known to be non-compliant. It's a non-compliant chamber. So any increase in occupation, cerebral spinal fluid, brain volume, or blood volume, any increase in occupation will yield a high pressure, because this is a known entity to be non-compliant. Not like your arteries, not like your veins, not like your heart, not like your fascia, not like your abdomen. This is a rigid container. So any increase in volume will cause an increase in pressure. And as volume increases, you always want to remember, as brain volume increases, blood volume goes down. When blood volume goes down, you now have opportunity for brain ischemia, because you're not delivering enough blood flow, you're not delivering nutrients, you're not removing carbon dioxide, and the brain, if you remember, is highly, highly dependent on oxygen and highly dependent on glucose. And in order for glucose to be delivered and in order for oxygen to be delivered, you have to have blood flow. Blood flow is going to be reduced when the brain is swollen, okay? So this whole relationship of volume and compliance, meaning the volume goes up, the compliance is fixed here. So that takes away so much that we have to know, like we have to understand what the heart and the vessels, we have to be able to talk about compliance and non-compliance. There's nothing about that here. You are non-compliant in your brain. It's not a compliant chamber. So whenever volume goes up, intracranial pressure will go up. Really, really important. And intracranial pressure normally in the cranial vault, the normal pressure in the intracranial surface, we measure that in the parenchyma, or we measure it in the fluid-filled chambers of the brain, the ventricles. The normal pressure is 0 and can be less than 0, actually, 0 to 15. That's the normal pressure in the cranial vault. At that pressure, 0 to 15, you still will have relatively good blood flow. You will have relatively normal flow of cerebral spinal fluid. But as the pressure starts to go up above 15, you're going to have reduction in blood flow and reduction in cerebral spinal fluid. Not reduction in manufacturing, but reduction in where that fluid is found. Okay, so again, looking at our brain one more time, like we looked at it before, is once you have that increase in your brain mass. So here you've got blood, you've got edema, you have dysfunctional brain, you've had an increase in your brain volume, you are accompanying that, so that increased to 84%. Now you've reduced cerebral spinal fluid to 9% and blood flow to 7%. So just remember, as that volume increases, what you're going to see is that blood flow will decrease, cerebral spinal fluid will decrease, and ICP will go up. Okay, so we look at that all together with a normal brain, a compensated brain, and an uncompensated brain. You can certainly see here, as you look at it, you can see with the normal brain, we have normal occupation and normal ICP, and our intracranial contents are staying right where they should be, and all is right with the world. But now I've got some increase in brain mass, and that's increased the brain occupation to 90%. So blood flow is reduced 5%, cerebral spinal fluid is reduced 5%. But we are still compensating here. But as the brain mass increases, so again, edema, free blood, tumor, as brain mass increases, I now go below what we're going to consider to be a compensation capability, and the intracranial pressure will be high, and you will no longer be able to adjust to make room for swelling. And when you can no longer adjust to make room for swelling, your intracranial pressure will go up extraordinarily high. And so we always want to be aware of that when we're talking about our patients, when we're talking about increased intracranial pressure. In your mind, remember that when intracranial pressure is elevated, and typically if it's elevated above 20 and sustained, so a little bump up to 20 and then back down to 10, people do that when they sneeze and they cough and hiccup, but an increase in pressure, and I'm going to say that what we consider acceptable is 20 or less, even though normal is 15. But a sustained increase above 20 tells us that you can no longer compensate, that now we're at risk for a profound reduction in blood flow and therefore brain ischemia, and a profound shift in the brain, therefore herniation. Now, we're not too concerned about your cerebral spinal fluid. If you have reduction in the accumulation of cerebral spinal fluid, we're not too worried about it. It just gives us really good information about what's occurring inside the cranial vault. Okay, so you'll see your mass got bigger and bigger. Yay. Okay, so you can see here what's taking up space. This is all blood, right? And it's taking up a huge amount of space. It's free blood. We've had a bleed. May not be intraparenchymal. It might be a subdural hematoma. It looks like it's a subdural hematoma. It's taking up a huge amount of space. And so what's going to happen is your two fluid chambers are here. This is your patient's right and left ventricles. Those are the lateral ventricles. And what often happens is one of the ventricles becomes compressed. Now, it's important to remember that in the brain, you have those two ventricles. That's the right and left ventricle. And those are fluid-filled chambers, but they're easily compressible. So what's going to happen is as you increase your brain mass, you start to compress those fluid-filled chambers. And that's really the first sign that we see when we look at somebody's CT. We also are looking at the dural fold. The dural fold should be straight up and down, but that dura is shifting over to my patient's left-hand side. This is his right, this is his left. So the dura is shifting over into the left-hand side. That actually puts that brain tissue at risk for compression and compartment syndrome, reduction in blood flow, and ischemia. And it happens pretty quickly if we're not observing and if we're not careful. And then you have the two side-by-side ventricles that we can see. My purpose here is not really to teach you how to read a CT or an X-ray, and I wouldn't tell you that I'm the best. I study it all the time. I take advantage of every reading that I can to understand it, but I'm not a radiologist. So always really just important to remember we're looking for a couple of things here. In this brain cut, this isn't a brain CT. Whoops. I'm looking for the dural fold up and down, and I'm looking for the presence or the compression of the fluid-filled chambers, the ventricle, and I also see that I'm occupying space, and that space is being occupied by a bleed. Okay, so you can see here as well, just looking at these chambers, okay, you've got this huge increase in mass that's taking up space, mass that's taking up space here, mass that's actually taking up space here, fluid that's taking up space here. Lots of things take up space, okay? And in all of these, what you're seeing is compression of the ventricles. which means that you have something called non-communicating hydrocephalus. What that actually means is that your ventricles are no longer creating and transporting cerebral spinal fluid. Probably never hear anybody use that term, although a neurologist would say it a lot. And the reason I say that is here you look at compressed ventricles, you can see they're really tiny. And here you're looking at really large ventricles. Large ventricles typically mean you have an obstruction in the drainage of your cerebral spinal fluid from your lateral ventricles. And these are people who get indwelling shunts over time. So somebody who comes to your emergency room was admitted into the hospital, who has had a change in mental status, who has a known issue with cerebral spinal fluid circulation, and they have an indwelling shunt, and then you look at their head CT and it looks like this, that means that you've got an obstruction in the shunt. Now that cerebral spinal fluid needs to get drained. For those folks, they have an internal drain, which often gets clotted and clogged. And in the ICU, we would just stick a needle right into that ventricle, called a ventriculostomy, and we would drain your cerebral spinal fluid. Because as you can see here, the majority of occupation is from the cerebral spinal fluid in the ventricles. That's the majority of occupation in the cranial vault. This patient would have an increased intracranial pressure. So again, I love neuro. I love to talk about neuroanatomy, physiology, pathology. I am not a neurospecialist, but I really love it. Most particularly, I love to talk about pressure and volume, which is what I really appreciate that I've spent my whole lifetime studying. And just to remind you that there's going to be a time, no matter where that patient is, that you're going to have to consider that you may need to monitor intracranial pressure. So first and foremost, a persistent GCS of less than 8 without exact explanation and causative facts, we're going to consider monitoring ICP. If what we've seen on your CT scan or your MRI, that you have significant intraventricular hemorrhage or hydrocephalus, we're going to consider monitoring ICP. Or if you are presenting with some clinical signs of herniation. From my point of view, by the time you're at herniation, it's a little bit too late. So I want to suspect this in any individual who has a neurologic deficit that is either is advancing under my care. I'm going to consider asking for ICP monitoring. Now, there's really a couple of different types of ICP monitoring. Here at Grady Hospital, we use intraventricular and we use subarachnoid. But there is also the intraparenchymal screw that allows you, we have that here at Grady. Only in the neuro unit is this done. This little screw that goes here into the intraparenchyma also monitors brain tissue oxygen. It's highly specific, and they really only do that in the neuro ICU, and they don't do it that commonly, so we're not actually going to spend any time on it. There also is the ability to place a small transducer into the epidural compartment. That's called epidural ICP, which is lovely because it's under the dura and it's not into the brain parenchyma itself. So some folks like that because they feel like that's better. It's not interfering with any brain tissue, but it is not commonly used, and we don't use it here at Grady at all. At Grady, we use the subarachnoid screw, which allows me to monitor your intracranial pressure and is only a little small area that actually has an external fixation into it. So that's really nice because the surface area involved can be very small. But most commonly, we use an intraventricular device. Now, what people typically call this, I always find this confusing, but I really try to cope with it. They'll call it extraventricular device, an EVD. Problem is, EVD could mean a lot of things from my point of view. So extraventricular, in this case, here when people say it, means that you have a device either into the ventricles of the brain or into the subarachnoid space of the spine. Either one of those is going to be called an EVD. But what we're talking about here today is the intraventricular device that is actually placed through the brain tissue and terminates here in the ventricular chamber, okay? Now, the beauty of this device is multifold. And the cons of this device are also multifold. The beauty of the intraventricular monitoring, which you might call an EVD, extraventricular device, is the intraventricular monitoring is very highly sensitive to any shifts in brain tissue. So let's just say I've got a free bleed right here. What's going to happen first and foremost is the ventricle is going to be compressed. As the ventricle is compressed, the chamber of the ventricle gets smaller, so the pressure that we're measuring will go up. So just reminding yourself how important that is, what I've just said, is that as the fluid increases in the brain, and here is my ventricular chamber, so I'm going to try to reproduce that. As the fluid increases in the brain and the brain is swelling, it's going to compress and it's going to make that ventricle smaller. So monitoring the pressure from that ventricle, because the chamber itself got smaller, the pressure will go up. That's an increased ICP. But the beauty of the intervention, because I can monitor that from any of these devices, I'll be able to see an increase in pressure. The beauty of this is that I can also drain your cerebral spinal fluid. So I can help make room for the swollen brain by draining cerebral spinal fluid. Okay, that's the reason we use intraventricular devices. They're very sensitive to increasing pressure or to compression of the ventricular bladder, and the ability to drain cerebral spinal fluid. Now, here's the really important thing about that. I can drain cerebral spinal fluid from that ventricle until the ventricle is completely compressed, at which point I'll no longer be able to drain cerebral spinal fluid. Doesn't mean your catheter is in the wrong place. It just means the chamber is compressed. So now I'm not really looking at a fluid-filled chamber. I'm looking at a totally compressed chamber. So there are lots of different methodologies: subdural, subarachnoid, intraparenchymal, epidural. Here we use ventricular, subarachnoid, and intraparenchymal. These are basically done only in the neuro unit. Occasionally you'll see something other than ventriculostomy in the surgical ICU, but it's pretty rare and it's not really well thought of. Really, those individuals have an intraparenchymal or subarachnoid device. They really want them over in the neurosurgical ICU, where people are really used to monitoring this, have a higher degree of understanding and interpretation, and follow a protocol for management of increased intracranial pressure. Okay. So I happen to say that I love the ventriculostomy because it gives me more opportunity to actually actively assist my patient by saying, if the pressure in the brain is greater than that, you should be draining. So if your pressure is greater than 18, you should be draining. If your pressure is greater than 15, you should be draining. And I set that up so that the patient will automatically drain cerebral spinal fluid when his pressure goes up. And I do that with my monitoring device. Okay, so again, if we look at that extraventricular drain, it's actually really easy to place. As long as you have ventricles that are open, it's pretty easy to place. The preference would always be to have a neurologist or a neurosurgeon, but others can indeed place this because you can basically look at this area that you have designated and just drill a small hole and then place the introducer directly into the ventricle. So it's the most invasive of all the methodologies, the most invasive. And it's very difficult to place in somebody who's already collapsed their ventricles. You shouldn't even try. Then you should just move to an intraparenchymal device, which is a screw, okay? And the subarachnoid screw. It's really nice because it allows me to do therapy, which is to drain your cerebral spinal fluid. And historically, on ventriculostomies, on intraventricular devices, you could actually zero reference the device. Now, I'm going to stop here and talk really quickly about setup. So it's really important to remember that we monitor two types of pressures. As nurses, we monitor two types of pressures. When we talk about setting up pressure monitoring, we monitor vascular pressures. That means arterial, venous, and cardiac, where there's blood flow. So vascular pressures, arterial, venous, and cardiac, and then non-vascular pressures, intrabladder, intrafascial, and intracranial. These are not vascular monitoring, which means that you don't have a pressurized flush solution. So from the device, which is in the brain, to the transducer, you have a fluid-filled pressure tubing column, but at your transducer, you do not have a connection to IV fluid to a pressurized bag. You don't want any fluid going into the brain. Why? Because it's a closed vault. You don't want fluid going in there, so you never hang it to a fluid-filled pressurized device. At the transducer, once you have flushed the pressure tubing, you have a deadhead on the end of the transducer that would normally be connected to fluid-filled tubing. Now, you still have a zero reference at your transducer, and you still have a connection to the patient, right? So that's really, really important. At the transducer, depending on what you're doing, at the transducer, you will have a secondary stopcock. That secondary stopcock, one end goes to the pressure tubing, the other end goes to a drain. And what's going to happen is that when my patient's pressure is greater than what I've set it at in my transducer, and again, my purpose here isn't to show you the whole setup, but just to remind you that when you set this up, when you set this monitoring up, you actually set a level above which your patient will drain their cerebral spinal fluid. So again, usually that's somewhere 10, 12, 15. Patient's pressure is greater than that in the cranial vault, they'll immediately start draining cerebral spinal fluid. Now, this is critically important for us because we're not going to turn off to drain, except the only time you turn off to drain is when you are actually monitoring real pressure. You have to turn off to the drain so that the patient's pressure goes to the transducer. All the rest of the time, you're turned off to monitoring and you're open from the brain to the drain, from brain to drain, so that that patient will drain their cerebral spinal fluid. You turn your stopcock in the wrong way, you could create a scenario where a patient could herniate. Really does require, from my point of view, relatively skilled nursing to care for a patient with an intraventriculostomy or any other ICP monitoring device, because we have to have a lot of understanding about it. It's actually a simple skill, just always remembering that you're not going to have a constant fluid column or a pressure bag attached to this, but you will actually, of course, flush out that pressure tubing prior to the hookup to the patient. Now, really, really important to appreciate that especially if you've had a subarachnoid hemorrhage or an intraventricular hemorrhage, that blood can actually push through the wall of the ventricle and accumulate in the ventricle and can form a clot. And then that clot can be at the tip of the ventriculostomy. Really important to remember that with a subarachnoid hemorrhage, one of the biggest issues with subarachnoid hemorrhage is blood enters into that subarachnoid space where your cerebral spinal fluid is, and that will actually occlude, blood clots will form and occlude reabsorption of cerebral spinal fluid, and blood clots can also appear in the ventricle. So you can actually clot off your ventriculostomy. Transducer should always be at the tragus of the ear, which is going to communicate with the distal tip of your catheter. So unlike your other leveling, most of you level to the mid-axillary point, right? Fifth intercostal space, mid-axillary point. Here, you're going to level to the tragus of the ear. So the tragus of the ear is just here at the top of the ear, and that's what you're going to level to. That's the big, big difference in leveling. And it's also really important to remember that outflow from the brain, venous outflow, cerebral spinal fluid outflow, venous outflow, is gravitational. So this patient will always have head of bed up above 35 degrees. And so what you want to remember is that that transducer has to stay at the tragus of the ear. The patient is sitting up. If you were leveling to their fifth intercostal space mid-axillary, you're going to have a very big difference between where the tip of the ventriculostomy catheter is and where your zero reference transducer is. So really pay attention to that. That's a critical and important piece when we talk about monitoring intracranial pressure. These are the other devices, the intraparenchymal devices, typically called Camino or Lycox or Codman devices. These can be used when we're not going to drain cerebral spinal fluid or it's already too late. The ventricles are collapsed and I can't get a ventriculostomy in there. So I'm just going to place a screw bit into the parenchyma, either the subarachnoid space or the parenchyma itself. These are pretty good, but they are not quite as effective in terms of constant monitoring. Big thing that happens with these devices, the only person who can zero reference is going to be the neurosurgeon, because they have to zero reference with the tip of the catheter out of the patient. Once it's in the patient, you can't zero again. Now, it's also really important to recognize that this won't be as global a measurement. It's going to be really more of a local measurement. Wherever I place that transducer, it's going to measure the pressure at that transducer. Well, meanwhile, more central or maybe on the opposite side of the cranial vault, the pressure may be going up. So that's really important for us to remember and understand and appreciate as we monitor our patients. Okay, so want to talk a little bit about ICP, the meaning of ICP, what's normal and what's abnormal. Okay, so very important to appreciate there is no normal. It really just depends on what your body position is, what your condition is, what's your age, what's the viability of your vessels and the tortuosity. Have you had some little ischemic stroke? So lots of different things affect it. But overall, we're going to say upper limit of ICP normally is 15. So anything that we see greater than 15, we're going to consider to be abnormal. It is important to remember that things happen where your ICP goes up, but your ICP should come right back down. Okay, so time to return to normal ICP is also important. The actual number of the ICP and the time it takes for the ICP to return to normal is very important. So when we're thinking about monitoring patients, we get assigned to a patient who has a ventriculostomy. We come in the room, we're monitoring ICP. Remember, 15 or less is normal. You might have significant increases above 15, but if they only stay for a short period of time, and that would be 20 seconds or less, as long as the ICP returns back to normal, first of all, you know that the patient has normal autoregulation. So they're shifting all the time. If ICP goes up, we're going to shift blood flow down. We're going to shift cerebral spinal fluid until the ICP comes back to normal. And then we're going to regain our blood flow, regain our cerebral spinal fluid regulation. Okay. So really important, if any of you have taken care of anybody with ICP, really important to understand that ICP is a very small waveform. Typically, because the normal is 15, we're going to view it at the bedside in a scale of 30 millimeters. So that's a small scale view, and it's a really small scale pressure. But it does have three basic upstrokes. The first one, known as P1 or percussion wave, actually correlates to your systolic blood pressure. Whew, pushing blood up into the cranial vault on systolic ejection, you'll have an increase in the intracranial pressure related to systolic upstroke. That's called a percussion wave associated with peak systole on your arterial blood pressure. Okay. Secondly, you're going to have what's known as a tidal wave. That tidal wave is the blood as it flows through the cranial vault. And that P2 or that tidal wave is the most important component of evaluating intracranial compliance. That's what we're all about. We look at the number, but we also look at the waveform to actually assure to ourselves what's occurring for our patient. That's really, really important. So I'm going to just tell you that your normal ICP, which should be very small, it's in a small scale, but you should see three variations. P1, systolic pressure, P2, flow of blood through the cranial vault, and P3, which actually is known as the dicrotic notch, just represents the closure of the aortic valve and that little pressure thrust that will be projected up into the cranial vault. So I want to take a look at that. P1, P2, P3. Okay, so this is the arterial systolic ejection. P2 represents intracranial compliance as blood flows through the cranial vault, and P3 represents a transient increase as the aortic valve closes. That's called the dicrotic notch. So P1, P2, and P3. Okay, so really important for us to understand these components and to appreciate that overall what we might see is your intracranial pressure overall is greater than 15, but once it's greater than 15, we're all about looking at the independent waveform components. So I want to just tell you, even if you've never seen ICP, it's really small. I might have to make my scale smaller so I can see it better. So I might change my scale from the monitoring scale, which is 30, to 20, or I might optimize it because I want to see the waveforms. And what I always expect is a downward step stool. P1 should be the highest, P2 next, and P3 least. Step down and step down. This is a normal ICP waveform. Now remember, the likelihood is it won't look like this if your ICP is elevated, but I might start seeing my patient's overall number elevate, and my responsibility as a bedside nurse is to go into that room, change the scale, and evaluate these components. And they're really clear. They come in a bunch of 3, pause, bunch of 3, pause, bunch of 3, pause. If I wanted to look at what was occurring, because I want to be sure I'm looking at P1 as systolic upstroke, I just correlate that to the systolic pressure on my A line. And I might do a dual channel recording to assure that those things are correlated. As your brain starts to swell and your intracranial pressure starts to go up, what you typically are going to expect to see at first is that your P1 is going to go up significantly. Because as the brain becomes a little less compliant and the chamber is a little smaller because I've got free water, free blood, brain mass, that systolic upstroke is going to create a much bigger wave. But that's going to be for a very short time that's going to happen, because pretty quickly you move towards this, which is now that the brain is non-compliant, the pressure during the blood flow through the brain, what we call the tidal wave, is going to be higher. Whenever that second wave, which should always be smaller than the first, remember you step down from 1 to 2, step down from 2 to 3. Okay, tidal wave, percussion wave, dicrotic notch. Just call them P1, P2, P3, just the 3 pressures of intracranial pressure. But once you've lost compliance, once you've lost the ability to compensate, what you're going to see is P2 is going to get bigger. And when P2 is bigger, this is actually prodromal. This is prodromal for herniation. Not worrying about herniation here. I'm going to try to get you under control. But here, I'm going to start worrying about herniation. What that means is if I'm the bedside nurse and I come on duty and the nurse before me says, yeah, he's had consistent pressure about 25 or 30. I've done this, I've done that, I've done this, I've done that. I go in the room, I say, first thing I'm going to do is look at your waveform. I look at your waveform and maybe it's at 26 pressure. And I change the scale so I can really look at it. Remember, it's going to be in groups of 3 with a pause, groups of 3 with a pause. Pretty easy to identify. I am not seeing separation between P1 and P3. I just see one great big spike, or I see that the second spike, that second step, P2, which is about the brain compliance, and as blood flows through the brain, basically diastolic pressure of the brain, I'm going to see that P2 get bigger. This is an emergency. Now, I call my attending team, my NICU provider, I say, P2 is bigger than P1. They're going to say what? I have no idea what you're talking about. What's the ICP? Okay, I'm all right with that. I'm going to call the neuroservice. And always it's best if it's neurology, because neurosurgery is not as interested in the waveform analysis, but neurologists are all about the waveform. If you call a neurologist and say, doctor, my ICP is elevated, my P2 is bigger than P1 or P3, they're going to say, I'm going to write some orders. I'm coming now. I'm going to send the fellow. I'm going to send someone else. I'm going to come and take a look at the patient, because this is prodrome for herniation. So I'm going to be all over this. I want to treat this patient effectively to stop them, if possible, from herniating, right? Reminding myself that when this P2 is bigger, you really have so much resistance to blood flow through the brain because so much space has been occupied. This is why we're concerned about your ICP. So again, I'll just give you this is of course an artist's rendition, but it won't ever look quite this clear, but it will be pretty clear. P1, P2, P3. When P2 is bigger than P1 or P3, that always means you have non-compliance, and you typically have lost your ability to compensate. You've shuttled off as much cerebral spinal fluid as you can, and you've reduced your blood flow to as low as you possibly can. That's what you're doing to compensate. And now you can no longer compensate, and the pressure inside the vault is so incredibly high. Okay, so I'm going to focus on, first of all, what is the value? Is it greater than 15, greater than 20, 30, whatever? And what is P2? Is my P2 bigger than P1 or P3? I'm calling the doc, I'm saying ICP is 30, P2 is significantly bigger than P1 or P3. And again, Your trauma surgeon may or may not know what you're talking about. Your medical doctor may or may not know what you're talking about. That's not their area. So I don't expect them to jump up and down. But if I call a neurologist and I say ICP is 30 and P2 is significantly bigger than P1 or P3, they're going to be jumping up and down. They're going to get downstairs. There's no, we'll see you after rounds or any of that. We're coming now because this is a significant predictor of cerebral herniation. We're going to do something about it right away. Okay, so again, here's kind of a relatively normal ICP. Here's an ICP where P2 is larger. And something else that's really important, this is ICP, but it's compressed over time. What you actually see is a very significant effect based on respiration. This is a spontaneous breather. So when they take their breath, the ICP will drop if they're breathing spontaneously. If they are getting positive pressure breathing, the ICP will go up when they get a breath. Goes up when they get a breath and down. It goes up when they get a breath from the ventilator and down when they take a spontaneous breath. But by the way, that's never going to happen because you're never going to see somebody with ICP who's spontaneously breathing. Oh my God. And then we also look at vascular pulsation that gets bigger and lower depending on patient's systolic blood pressure. Okay, so again, we kind of look at normal, high, medium, low, stepping down from P1 to P2 to P3. P2 gets significantly bigger than P1 or P3. This is potentially pathologic and is a predictor overall for herniation. When P2 is up and P3 starts getting pulled up, this is most likely pathological. And then you see the disappearance of that little dicrotic notch. I'm not going to worry too much about it. What I want you to recognize is P2. And as P2 gets bigger, that you're actually becoming more and more pathologic. And when you get here, so you don't have any differentiation of P1, P2, and P3. When you get here, this is pathological. Your patient's going to herniate. And they're going to herniate now. So you always want to see these waveforms, even if P2 is higher. And most of the time when you're evaluating ICP, it's going to require that you actually put this visual into a scale where you can actually see the waveforms. You cannot flush this. The only person who can flush it is the neurologist, because when you flush, you're putting fluid into the cranial vault. You don't want to be doing that. That is not something you as a nurse do. It is a sterile procedure and only a neurologist or his designated provider. So a neurology resident, a neurology fellow, a neurology APP, but a bedside nurse does not flush the ventriculostomy. Only the neurologist or their approved provider, because it is possible you could clot. The thing is that when you clot, you don't get this. When you clot, you get it flat, right? You're clotting, so you're not seeing any pressures. So when you come in the room and you see a flat ICP and you say, let me make a scale that's more appropriate. Oh, the ICP is 18, so let me put it in a 20 scale. I put it in a 20 scale, I still don't see any waveforms. Okay, that typically means that you have a clot. If your ICP is elevated and you can't see any waveforms, that's pathologic. And that means your patient is getting ready to herniate. Once they herniate, guess what? When they herniate, their pressure drops because they broke out of their confined space and they went down onto the spinal cord. They herniated through the uncus, and now the brain is down into the spinal cord. Now, of course, that's terminal. Herniation from right to left, herniation from up to down, that's terminal. It's a terminal event. So that's a really important concept. Okay. Now, the last thing I'm going to say, because of course, it's getting close to time now. So last thing I want to say is the other discussion that we have about ICP. We look at the individual three-part P1, P2, P3, and the individual pressure, which we're very concerned about. But we also look at sustained intracranial pressure over time. And for a lot of people, this can be very confusing. I think from myself, when I started really looking at ICP, and that was really like in the early 80s, it was really confusing to me overall. And I think it was confusing to a lot of people. In fact, in the early 80s, we didn't look at individual components. We just looked at sustained elevation over time. Now, that's a really important thing for us to say, because if I'm at the bedside and you're at ICP of 25 or 30 or 40, and it's sustained over time, that's actually categorically telling me how significant this is. Okay, so we have A, B, and C, and what we really want to talk about is A. So we talk about this as waves, but it's not really waves. Sustained increased intracranial pressure over time. Okay, if you have an ICP that is sustained, and now we talk about 2 minutes, not really 5 minutes, 2 minutes time sustained over 50. So ICP is greater than 50 and it's sustained there for 2 or more minutes. That's called a plateau pressure or an A pressure. It means elevated pressure sustained for at least 2 minutes at 50 or above. You've completely lost compensation, and this is a predictor for death. This is actually preceding herniation and death. So one of the things is to call your doc and say, ICP is sustained over time. It's been greater than 2 minutes. It's up at 55. I've done everything I can. I've sat the head of the bed up. I make sure the neck's not angulated. I've given sedation. I've given analgesia. We've given hypertonic saline. We've given mannitol, but the patient has sustained elevated ICP. This is important because this is the time that we're probably going to call the family and say, the time is near. We'd love for you to come and spend some last moments with your loved one. The time is near. Because once this happens, there's very little I can do. Okay. The second one is called the B waves. B waves means you have elevated ICP, sustained, typically for a duration of 1 to 2 minutes of 20 to 50. Now, remember what I said to you, like you go in and suction a patient, their ICP is going to go up, but you expect that to come back down in about 20 seconds. ICP is up and stays up for greater than a minute. It's greater than 20 for greater than a minute. That means that you have decreasing capability to compensate. And compensation means reducing blood flow, reducing cerebral spinal fluid. Well, now you've got reducing compensation. So this is prodrome for the A wave. And it is telling us that the patient is getting worse. Okay. You can't believe how many times I see people charting ICP 30, 35, 28. And what physicians will come back and say to me is, why didn't they do something? Why didn't they call somebody? How come they didn't, notify neuro? Really, because that's really who you need to notify. I've got a patient with an ICP of 28 and it's sustained greater than 2 minutes. It's sustained at 28. That means your patient can no longer compensate. So there really are just a few things we can do, right? We can try to remove free water. We do that with mannitol, or we do that with hypertonic saline, mobilize free water into the vessels and get rid of it. Mannitol, hypertonic saline. Move free water from the brain, move it out. Above everything else, that patient's glucose must be controlled. If they're hyperglycemic or hypoglycemic, you're going to damage them and cause an elevation in their ICP. Head of bed needs to be up, room needs to be dark, room needs to be quiet. So you're not yelling and talking to your friends and calling out of the room, hey, I need that washcloth. None of that. Room is dark, cool, calm, quiet. Family members come in the room before they enter. You just need to say, we want the brain to rest. If the brain is really active, if you're trying to get the patient to wake up, you're trying to stimulate them, telling them to open their eyes, it's going to cause increased brain activity, and they just don't have the ability to sustain that right now. So you can only be in the room. You can certainly hold their hand. You can be there and very quietly and very calmly, because a lot of times families come in the room, they say, open your eyes, Derek, open your eyes. It's mama. I'm here. Open your eyes, open your eyes. And the ICP goes from 12 to 24, which means that they're recognizing something is going on, and they may recognize mama's voice. We don't know, but it's too much stimulation. So cool, calm, dark, and quiet, head of bed elevated, always want to be draining cerebral spinal fluid. If you have a ventriculostomy, make sure it's always open to drain. You only turn it off to the drain and open to the patient at the time you need to monitor what the ICP is, which is intermittent. You always keep it open to drain, so it's always draining anytime the pressure is elevated. So we set our level, and that's basically a little ruler. We set a level that says anything above 10, patient should drain. And so you just intermittently every hour just turn the stopcock off to the drain, which is at the bottom, so the patient's tubing is communicating to the transducer, and you chart what their pressure is, and then you open them back up to drain. Woe is you if you have a patient who should be draining, but you turned your stopcock the wrong way, or you just didn't think that you were supposed to always leave it open to drain. So one time I came in a room with a patient who had ICP. Of course, there was, you know, the thing is, people think they're so magical. They turn the stopcock all the way up, so you're both draining and monitoring at the same time. That is not the way to do things. You open a drain, turn off to monitor. But I came in the room one time with the stopcock turned down to the drain, and the patient's ICP was 31. Now that patient needed to be draining, probably for an hour needed to be draining. Even just a cc of fluid will reduce that intracranial pressure. You never actually pull it off. It's just a passive gradient. When the pressure in the brain is high, pushes cerebral spinal fluid out into the drain. And draining is one of the best things that we can do for patients who have increased ICP. So make sure your preceptors are showing you how to do the stopcock. Make sure you know how to do the stopcock when you're precepting others. And really consider, you always want to turn off to monitor, open to drain, except intermittently when you need to monitor the pressure. So in the neuro ICU, they never turn the stopcock all the way up, so you're both draining and monitoring. There's no reason to be worried about the monitoring. While you're draining, you're draining. You only monitor when you monitor. So in neuro, they would never do that. But when you go to other areas in the hospital, especially with people who are less familiar with ICP, a lot of times they turn the stopcock all the way up, so you are both draining and monitoring, which means neither of which is being optimized. So don't do that. Please don't do that. So I'm really only want to talk about A waves and time periods. Those are called the plateau waves, and B time periods. And the difference between the two is how high the pressure is and how long it persists. Remember, for plateau, pressure is typically greater than 50 and persists for greater than 2 minutes. And for the B waves, the pressure is greater than 20 and persists for 1 to 2 minutes. Remember, all of us will have ICPs that go up into 50, but it should come back to normal immediately. Now, that resolution in time is also really, really important in terms of predicting what's happening for the patient. So there is so much more to talk about and a lot more to say. I'm going to make that part 2. That will be next Tuesday's topic, the second talk of how do we manage ICP? How do we treat it? What are we going to do? And how do we communicate it? I'm so grateful that you've joined me here today for Tuesday Topics. I thank you very much. I'm grateful for everything that you do. I'm going to stop recording and sharing, but please stay on if you have questions. Thank you. I'll see you tomorrow, or I'll see you next week, hopefully. And thank you again for all the hard work you do every day.